A continuación sigue actualización en esofagitis eosinofílica. Esta nos la acompañará y nos la dará el doctor Jonathan Spergel, es pediatra de Yale y de New Haven Hospital, alergia e inmunología clínica del Children's Hospital en Harvard, profesor de pediatría de la Facultad de Medicina de Perham en Pensilvania, y es el jefe de la sección de alergia y director del Centro de Trastornos Eosinofílicos Pediátricos del Hospital Pediátrico de Filadelfia, y es editor adjunto del análisis de Allergy, Asthma and Immunology. Entonces, a continuación los dejo con él.
Good morning, and thank you for inviting me to speak at your conference. I am very, very honored. So I'll be speaking about eosinophilic esophagitis, or EOE. We'll talk a little bit about diagnosis, management, and treatment. Our learning objectives are really threefold. One is to describe the symptoms of eosinophilic esophagitis. Two is review evidence-based treatments for eosinophilic esophagitis. And finally, look at monitoring. So these are my disclosures, and I do a fair amount of work on EOE, so I've gotten lots of grants on the topic. Just really sort of going a teeny bit of background before we start. I mean, EOE was originally first described in sporadic cases of back starting as early as 1970, but really became an entity when Kevin Kelly first described that the relationship between food allergies and EOE back in 1995. The first real consensus review was really published in 2007. It is really expanded in the literature rather dramatically. There have been two recent updates, and we'll go over that on consensus recommendations and diagnostic criteria, one in 2011 and one in 2018. And almost all the guidelines and all the publications have really been in the last several years. Instead of being a couple case reports back 30 years ago, now we have had 3,100 publications in the year 2021. So it's the number of cases, the number of stuff is really driven dramatically. So what is EOE? The symptoms of EOE really do vary by age. It is a male predominant disease, and the symptoms really vary because it's a disease of the esophagus. The symptoms vary on how much damage you have in the esophagus. So in infants and toddlers, it hurts to eat, so they present with food refusal and failure to thrive. Older children present with vomiting and abdominal pain, and adolescents and adults really present with sort of the classic dysphagia and food impactions. But even adults occasionally can present with heartburn and reflux. Unusual, but definitely can happen that way. The definition from 2011 is still the same definition. There's been a minor tweak, which we'll go over in a minute, but it is a chronic antigen-mediated disease, and it's a food trigger. You get an esophageal disease with this dysfunction, which causes the symptoms we just talked about, and you get this eosinophilic inflammation. An adult and pediatric is the same disease. The response is identical to therapy. The one difference which was published 4 years ago now, was we used to have this issue of you had to fail a PPI, or proton pump inhibitor, beforehand. And it was found that PPIs have this anti-inflammatory effect working on STAT6. And patients were found that they responded to PPI and diet. So there was this overlap. But interestingly, it's not a complete overlap, and it's a little hard to tell, because we definitely see patients who fail diet and fail swallowed steroids and respond to a high-dose PPI. So the two overlapping circles, how completely overlap is a little still, I think, unknown. But when we think of EOE, we have the symptoms we talked about, and this is really important. We have to get a biopsy. It's the only way to monitor disease, because symptoms don't always correlate with histological findings. So anytime you do a change or do a diagnosis, you need a biopsy. A biopsy for EOE is you have to have greater than 15 eosinophils per high power field, which is about 60 eosinophils per millimeter squared. And you will have to rule out other things that cause esophageal eosinophilia. The things like reflux can do it, eosinophilic GI, gastrointestinal disease, when you have eosinophils up and down the GI tract, is a different disease. Celiac disease can cause it, IBD can cause it. So you really have to make sure that you're a good clinician and you rule out those other causes of esophageal eosinophilia. When we think briefly about pathogenesis, it's a very genetic disease. It's much more common in males and females, and people have looked. This is one of the more recent GWAS things, and every time we look, we find new loci. The most common, the two big loci that people have identified is TSLP, which is really important and alarming, that plays a key role in the genes. There is caprin-14, which is an esophageal marker, and then there's also MC, which is a transcription factor, all play a role in the general pathogenesis of disease. But it's simply not genetics, because if it was, then every monozygotic twins would have it. So this is a twin study done out of Cincinnati. And as you can see, monozygotic twins, about half get EOE. So there is a really genetic factor, because if it was no genetics, it would be the same as the general population, which is 1 in 2,000. But if it was all genetics, it would be 100%. So there's an environmental genetic factor. And there's probably a large fetal factor, because siblings and dizygotic twins should be the same. If it was just genetics and some general household environmental factor, that being a 10-fold difference suggests there's something happens in the newborn period that creates a large risk factor. What that is unknown. Is probably similar to other we see in risk of atopic disease, perinatal antibiotics, C-sections, exposures to various toxins, all probably play a key role. Exactly what they are, we do not know. All right. It is when we think about, I'm going to go briefly over pathogenesis, because it's important when we think about this. EOE, even though it's an eosinophilic disease, it's probably a T cell driven disease more than an eosinophilic disease. And this is a paper out of the MGH group that you can see that there's a large number of T cells involved in the disease. And you can see it's also mast cells involved, and particularly the CRT2 T cells. So there's really a Th2 driven disease. When we think about it from a really overall picture, we have some trigger that sort of damage the esophagus, that triggers the alarmins, the IL-33 and the TSLP, that triggers a shifting to a Th2 pathogenesis, the IL-4, IL-13. These then stimulate STAT6, which causes the barrier to leak. And then when the barrier leaks, the antigens come in more, you sort of get a circle. You also get activation of remodeling from STAT6 or periostein that causes the remodeling of disease. So these things do trigger each other, and you get an overall view and increasing along the lines. So now let's jump to treatment. When we think about treatment, we always have to, it's what we like to call a shared decision-making. It's a conversation with the families of what do they want to do and what the benefits and risks, because there are options. We have to first make sure the patients really understand what they have, that it's a chronic disease and you need to monitor it over time. There are three basic ways we treat disease: nutritional therapy, pharmacological therapy, and dilatations. Dilatations really are acute fix and not really meant for chronic treatment, because they only open the esophagus, help acutely with symptoms, but don't really treat the underlying disease. So nutritional therapy is, since there's a food trigger, you can do various elimination diets, which we'll go over in a second. Pharmacological therapies are usually off-label use of topical steroids, and recently the use of biologics. So I'm going to go over the oral viscous budesonide. So this is the one that's approved in the EU, and you can see it had a significant improvement in both. So this is the clinical histological improvement, so about 57% compared to 0. they had, and this was basically having less than 5 EOs per high power field, which is the FDA endpoint they look at. And you can see that patients really begin to show some improvement by week 2, but then continue to improve over time. As you look at anything, there are risk factors in the drug. As you can see, there was about a 20%, actually about, sorry, a little bit higher, but yeah, 23% of a local fungal infection, which is pretty high. We tend to see a little bit less clinically, but that's what they saw in the study. So that is a significant thing you need to look for. But there was really, otherwise, that's the main trick. And this was done on a very high dose in adults. The other form of swallowed steroids that are being explored for the treatment of EOE is fluticasone powder. And this is in a phase 2 trial. And we look at 2 different figures here. The top figure is looking at the use of improvement in eosinophil counts. As you can see, the higher doses of 3 milligrams BID work better than the lowest dose, the 1.5. There's pretty much equivalent between the 3 and the 1.5. If you look at the bottom, which is the episodes of dysphagia accounts, again, the 3 higher doses seem to work relatively equivalently. Now let's look at side effects. Let's looking at candidiasis, and you can see the higher doses from the 1.5 twice a day, the 3 once a day, and the 3 twice a day have about a 10% candidiasis effect throughout the 2 trials, but esophageal candidiasis on the higher dose was up to 30%, so which was pretty high. This is a phase 2 trial, and additional studies will need to look at whether they can see the sustained effect and looking at additional safety as the new trials continue along. Since EOE is a food-triggered disease, the other way to looking at it besides biologics is food avoidance. And we originally looked at it from a regular food allergy perspective. This is a study that we accomplished over 10 years ago. Most patients with EOE are highly atopic, so they have asthma or allergic rhinitis. When you did allergy testing, so standard allergy testing, whether skin test or blood test, that only identified triggers about 15%, really indicating that it's a non-IgE made way. And the most common foods we identified was sort of milk, egg, soy, and wheat. So if you really began to look at it, how well allergy testing looked, that worked about 50% when you did sort of looking at immediate and delayed testing, but you can do just as well by guessing the so-called 6 food group and elimination diet, which is a diet that's really pioneered by Amir Kalawagar out of Northwestern. And his data really showed when you did the 6 food group elimination diet, similar to what we found in our studies, there's primarily milk, wheat, egg, and soy. And most patients in his small series was primarily one food, about 70% were just one food. When they looked in a larger study now in more children, the data was similar. So about 60% was one food, and about 20% was 2 foods. And again, it's primarily milk, egg, wheat, and soy in most of the patients. So they had a response rate about 60%. Now, there's been a study done by the NIH, part of the SICA group, and this is the data where they compared 1 food versus 6 food in adults. This was the adult trial where patients were really randomized, and they almost had identical effects. The 6 food group was teeny bit better, but definitely not statistically significant. When you did it in pediatrics, this was again part of the same NIH consortium where patients were randomized for 1 versus 4. And we looked at both symptoms, which was by a primary endpoint called pediatric eosinophilic esophagitis symptom score. There was a trend for an improvement that in the 4 foods was slightly better, but histologic response was identical, and quality of life, people liked 1 food versus 4 foods. So if you really want to do diet, it's probably the best way to do is just start with milk. It will work both in children and adults, about 30 to 40%. So that's probably the current recommendations for dietary therapy. What about this IgE and EOE overlap? This is a big issue for us in the allergy world. We know that EOE is not an IgE-mediated disease. We know that skin testing, as I mentioned before, does not work. If you block IgE with omalizumab, it doesn't work. In a mouse model, if you knock out IgE, it doesn't matter. Oral immunotherapy really doesn't induce things. But there is a large overlap. So a lot of patients with IgE-mediated food allergy get EOE. And this was a breadth cohort study that we did at CHOP. And we had follow-up patients who were in our primary care network. And we looked at all the patients who had IgE-mediated food allergy. And then we looked at the rate of EOE in that population compared to the normal population. And it was about a 100-fold increase. So patients with IgE-mediated food allergy and probably other atopic diseases are an increased risk. So there's part of a general Th2 skewing in these patients. The other thing is that's a popular thing now in the United States is oral immunotherapy. So oral immunotherapy is the way to treat IgE-mediated food allergies. You do a desensitization. And if you look at how commonly patients get EOE-like symptoms, it's going to range almost as much as 20%. If patients get EOE by biopsy, probably about 5%. So when these patients probably have two things causing disease, both the foods causing two diseases, not only anaphylaxis, but EOE. So this is a issue when we do oral immunotherapy, or if you see patients on oral immunotherapy, you're now getting GI symptoms, you really need to think about EOE. The last thing is when you do food elimination, can you sort of get anaphylaxis afterwards? It is extremely rare, but there have been case reports. So there have been about 5 case reports in the literature. When we looked at our institution, we had about 2 out of our 3,500 patients. So rare, but it's not zero. So these are patients who avoided the food, reintroduced the food, and triggered it back. So these patients, when I would worry about this, if a patient had anaphylaxis to the food, outgrew it, then got EOE to the food, I would be a little nervous about adding that food back in at the time. All right, so now let's talk about biologics. So this is the new hottest thing in the field. So there've been a few biologics and one recently approved in the United States. So this is IL-13. So IL-13 was one of the ones published originally. And as you can see, we look at 2 basic things in all of our studies. One is eosinophil counts, and you can see looking at, we want to see less than 6 as sort of the endpoint, and that's panel C here. And you can see on the low dose, it was about 25%, and high dose is about 20% reduction in eosinophil counts less than 6. That's sort of the endpoint. You see improvement in endoscopic scores and an improvement in dysphagia, which is the DSD, which is panel D. So there's really generally an improvement in our patients. In the study, it seemed to be relatively safe. And he's having some mild headache, but no serious side effects. And this drug is now going in phase 3 clinical trials looking at our approval. What about other anti-IL-5? So these are 2 drugs that are approved in the United States for the treatment of asthma, resolizumab and mepolizumab. They did not have a significant improvement at all in symptoms, and the eosinophil counts did improve, but very few patients had down to that less than 6. So I was the author in the resolizumab study, and you can see in panel A, patients got better on the high dose, but very few patients got down to that less than 6. That really suggested what we talked about earlier in the pathway, that EOE, even though it's an eosinophilic named disease, EOs are probably not the endpoint of the disease. They're probably just part of the pathogenesis. And if you just block EOs, it's probably not enough, which is consistent with a recent study on the cyclic 8, which has been out only in abstract, which showed they really knocked eosinophils down to 0, but symptoms did not improve as well. So what got approved in the United States is dupilumab or Dupixent, and this was the TREAT study, the Liberty EOE TREAT study, and it had 2 study designs. In part A, patients were randomized to placebo versus weekly dupilumab, And then in part B, they were randomized to weekly versus 2 weeks versus placebo. So let's look at the data. So in part A, looking at the weekly data, you can see a significant improvement in eosinophil counts less than 6. So about 60% of the patients got better, 59.5 and 58.8 in the weekly dosing. So this is looking at peak eosinophil counts and changes, all highly significant in all those lines. What about symptom improvement? The weekly symptom improvement was highly significant in the weekly dosing for both changes in baseline and absolute changes along those lines. And this is looking at EREFs or endoscopic scores, which is, again, significant improvement in the weekly dosing of dupilumab versus placebo. Last thing you always want to look at is safety. It seems to be relatively safe. Again, looking at in the placebo versus active, there was really no statistical improvement besides injection site pain. Everything else is sort of completely overlapping between the two study drug and placebo. Based on this, the drug was approved in the United States on weekly dosing for treatment of EOE. I want to briefly go over what we've been doing before it got approved. So many of our patients with EOE have other atopic diseases. So we went back and looked at our patients with EOE who had dupilumab approved for their asthma or atopic dermatitis. And so we looked at those patients, and we actually ended up having 45 who had a dose and 26 who had follow-up endoscopies. Not surprisingly, when we looked at their effects on what the drug was approved for the atopic dermatitis or the asthma, their asthma and atopic dermatitis approved in their patients. But was also interesting when we looked at their eosinophil counts or looked at endoscopy scores or the symptom scores, almost all had significant improvement. Not everyone got completely better, but you can see there was a marked improvement, and the dosing was every 2 weeks, which suggests some patients can respond to every 2-week dosing instead of 1-week dosing. But additional studies need to be done whether over time we can wean our patients from one to the other. So really, I want to end and talk about, there is a clinical diagnosis. It has overlap with asthma and atopic dermatitis as part of that general Th2 skewing that we see in our patients. Our treatment really is, you can do diet, primarily milk, you can do swallowed steroids. Biologics now are an option. You can do combinations of things. And I didn't talk about it, but there is a small subgroup that are truly aeroallergen driven, and those patients do respond to subcutaneous regular allergy shots, but it's a very small subgroup. And we do need to monitor and treat disease, because untreated disease we know is a risk factor for strictures. And the way we have to monitor them, as we mentioned before, is really doing an endoscopy with biopsies, because there's a really poor correlation with symptoms and biopsies, unfortunately, at the current time. So thank you, and I hope you enjoyed my talk.
Buenas tardes, doctor. Mil gracias por estar con nosotros, por la charla, por ponernos en contexto de en qué estamos y la importancia del tratamiento de la esofagitis eosinofílica. No sé si en el auditorio hay alguna pregunta para el doctor Spergel. Yo tengo una. Hay un número de eosinófilos que nos dicen que mayor de 15 es el diagnóstico en endoscopia. Pero ¿cuándo vamos a saber que ese paciente muy probablemente no nos va a responder? ¿Hay algún marcador que nos diga que ese paciente no nos va a responder ni a los inhibidores de bomba de protones o al esteroide de glutido o a la dieta y que tengamos que avanzar a biológicos? Porque es que uno ve el paciente con 300 eosinófilos y uno no sabe si va a responder a alguno o si es en el tercio proximal y no en el distal. Hay algunos feelings para uno, pero no hay un marcador específico que uno diga, bueno, este no me va a mejorar.
Buenas tardes. That is a great question. A great question. Unfortunately, as you said, there is no marker. Patients with a count of 100 can respond to diet, can respond to a proton pump inhibitor, or can respond to swallowed steroids. It is really at this point a process of trial and error, and which one to start with really is a conversation with the patient of the risks and benefits of each option. So we don't have a marker yet. I wish we did, but we do not.
El doctor Chapman.
Gracias, doctor Spergel, por su conferencia. Quería preguntarle, con dupilumab hemos observado, bueno, y está descrito en la literatura, que existe la posibilidad de que hayan algunos pacientes eosinofilia con su uso. ¿Hay algún, pues tal vez el número de pacientes en los ensayos clínicos no sea el suficiente? ¿Se observó en algún paciente presencia de eosinofilia o empeoramiento de su condición en los estudios?
So, in general, I have not seen in any of the patients their EOE, their asthma or atopic dermatitis have gotten worse. People have seen peripheral eosinophil counts get worse. The clinical significance of that is unclear. It may be moving of the eosinophils from the target organ to the blood. There's some studies suggest that these eosinophils that are higher in the peripheral blood may be inactive, but I think it's unknown. But we have seen some side effects, not with the in the EOE population, but the atopic dermatitis population. You've seen some patients get facial atopic dermatitis, which seems to be exacerbations of a fungal infection that seems to be occurring that responds well to topical fungal ointments. But we've not seen generally worsening of EOE or worsening signs of asthma, maybe a little atopic dermatitis.
Thank you. El doctor Olmos me iba a preguntar. Dolly, es que solo tenemos para una pregunta adicional.
Vale. Los lactantes, en este grupo etario es muy frecuente la clínica de reflujo gastroesofágico. ¿Qué signos o síntomas me deben prender las alarmas para sospechar una esofagitis eosinofílica en este grupo de edad y considerar la realización de una endoscopia?
That's a great question. When would you worry a patient with reflux is not getting better? So in my mind, if a patient doesn't get better on reflux medicine, so if you put a newborn on reflux medicine, they get better, I wouldn't worry about it. If they don't get better, or after infants typically outgrow the reflux by 1 to 2 years, and you can't get them off the reflux medicine after 6 months or 9 months, anytime you stop it, their reflux comes back, then I would worry then about possibly being EOE, because you can't start it, right? It's a great question. Thank you.
Y para que no me digan algo, el doctor Olmos tenía la última pregunta.
Gracias, doctor Spergel. Quería preguntarle si hay algún reporte de mejoría o no con la asociación de EOE con alergia a aeroalergenos y su tratamiento con inmunoterapia. Y la segunda era si con horneado se afecta o no los síntomas y el tratamiento ayuda o no.
So for the first question, do people get better with immunotherapy? So from allergy immunotherapy. So in allergy immunotherapy to pollens or dust mite, there's a couple case reports, no placebo-controlled trial, but couple case reports and case series of people improving with subcutaneous immunotherapy. And for sublingual immunotherapy, it's the opposite. There's case reports of people actually getting EOE from sublingual immunotherapy. In the United States, if you read the package insert, sublingual immunotherapy, one of their side effects, they list EOE. So it's actually, you think about it, it's not surprising. You're swallowing an allergen, just like you're swallowing the food, so these patients who swallow allergens can get exacerbations of their EOE from the pollen. And the second question, what was the second question? I forgot, sorry.
Con horneados, doctor, que si al hacer terapia con horneados en pacientes con alergia alimentaria van a hacer esofagitis eosinofílica con esos horneados.
Oh, okay. Okay, with baked products. So
Exactly.
someone who has milk-induced EOE, there's been one publication and lots of offhand conversations, not a lot of data, but about 50% of the patients who have milk-induced EOE will seem to tolerate baked milk. So I think it's very similar to what we see with IgE-mediated food allergy. There is no data on eggs, but my observation is, again, about half the patients with EOE who have egg-induced EOE can tolerate baked eggs. So I think it's very similar to what we see with IgE-mediated food allergy. Maybe a half of them can tolerate baked goods.
Bueno, muchas gracias, doctor Spergel. Esperamos que podamos verlo pronto por acá y gracias a todos por la participación.
Thank you so much. It was my pleasure. Hopefully I can visit in the near future.